Good day, everyone. I am Dr. Thea Castillo, and my task for today is to discuss maternal nutrition in the first 1,000 days of life. I have no disclosures and conflicts of interest. Nutrition is a critical part of health and development. Better nutrition is related to improved infant, child, and maternal health, stronger immune systems, safer pregnancy and childbirth, lower risk of non-communicable diseases, and longevity. We have come from a history of malnutrition being synonymous with undernutrition. While undernutrition remains a major challenge worldwide, we are now faced with the negative effects of overnutrition in the form of obesity and risky nutrition in the form of unbalanced diets or diets contaminated with potential toxins. Undernutrition and overnutrition coexist, and women are doubly vulnerable because of their high nutritional requirements for pregnancy and lactation. So, malnutrition may be due to different causes that start from the bigger picture, like the economic status of our country, to the smaller scale causes, like unhealthy food choices because of lifestyle in the 21st century. The Food and Nutrition Research Institute, or FNRI, undertakes researches that defines our citizenry's nutritional status, with reference particularly to the malnutrition problem, its causes and effects, and identify alternative solutions to them. The Expanded National Nutrition Survey is a comprehensive survey conducted every 5 years since 1978, and the latest of which is in 2018. 81 provinces were included in the sampling domain. A response rate of 87.9 for household and 81.5 for individuals were gathered respectively, with a certain percentage in women respondents. This slide shows the trends in the prevalence of nutritionally at-risk pregnant women from 1998 to 2018. This graph depicts the prevalence of nutritionally at-risk women showing a decreasing trend but not significant at 5% level. The prevalence of anemia among pregnant and lactating women has decreased throughout the years, but has remained a problem of moderate public health significance. This slide shows the prevalence of chronic energy deficient and obese lactating mothers. The percentage of CED lactating mothers also has a decreasing trend from 2011 as presented by the blue graph. The red graph representing the rate of overweight and obese mothers has been steadily increasing, rising from 17.7% in 2011 to 28.5% in 2018. How does maternal diet influence fetal outcome? In 1986, an English physician and epidemiologist, David Barker, proposed findings wherein early adaptations during fetal life prepares the individual in response to future environment hazards. He published findings which suggested that health outcome of individuals stems from events that the fetus underwent during prenatal life, implying that the fetuses, as they enter the outside world when they are born, would be more familiar and easily adaptable due to fetal cues from which they are exposed to while in the mother's womb. Thus, a strong association between maternal nutrition and poor infant nutrition exists. Undernourishment during critical periods in development can lead to adverse health outcomes and can increase the risk of developing non-communicable diseases such as diabetes, hypertension, cardiovascular diseases, as well as maladaptive responses in the child, as a way to compensate for poor nutrition. What then are the effects of maternal undernutrition to the fetus, the child, and eventually the adult? In cases of maternal undernutrition, there is preferential shunting of available nutrients or glucose to the brain and the heart due to decreased fetal secretion of insulin and increased peripheral insulin resistance. Thus, glucose is delivered less to your skeletal muscles. The pre-programmed physiological alterations that occurred during fetal life are due to adaptive mechanisms that the fetus underwent as a response to events of stress and decreased resources inside the womb. Moving into adulthood, if the individual remains lean or continues to maintain a healthy diet and lifestyle, it wouldn't be a problem per se, since the body is already pre-programmed to survive an environment with limited resources. However, when the individual becomes overnourished in the future, since the individual is pre-programmed to insulin resistance, glucose becomes malabsorbed, hence more likely to develop different conditions such as obesity, DM type 2, and the metabolic syndrome. Micronutrients' impact on a body's health are critical, and deficiency in any of them can cause severe and even life-threatening conditions. Micronutrients perform a range of functions, including enabling the body to produce enzymes, hormones, and other substances needed for normal growth and development. What are the maternal and fetal health risks associated with micronutrient deficiency? Let's discuss each one of them. Iron deficiency remains the leading single nutrient deficiency worldwide, affecting over 2 billion people, including 30% of pregnant women in industrialized world, with higher rates in developing countries. Iron deficiency anemia results from poor dietary intake of absorbable iron and loss of iron through parasitic infections or blood loss. Iron deficiency anemia have been associated with greater risk of preterm birth, low birth weight or small for gestational age infants, impaired maternal function, and decreased defenses against infection, as well as abnormal psychomotor development and cognitive function in infancy. Night blindness affects up to 7.8% of pregnant women globally, while 15.3% are considered deficient based on serum retinol concentrations. Studies suggest that maternal night blindness correlates with a higher risk of infant mortality and low birth weight infants, yet vitamin A supplements have not shown any benefit in preventing these outcomes. Your vitamin B6 and B12 acts as coenzymes in intermediary metabolic pathways for energy generation and blood cell formation. Vitamin B12 functions alongside folate in processes which is essential for the methylation of your DNA, RNA, proteins, neurotransmitters, and phospholipids. Deficiency in these vitamins can therefore impact on cellular growth as well as on nerve tissue development due to its high energy demand. Only small amounts of iodine are required to prevent deficiency. Yet iodine deficiency disorders, or your IDDs, remain the most common cause of preventable brain and cognitive impairments worldwide. Approximately 1.8 billion people worldwide have iodine insufficiency, with Europe and Southeast Asia having the highest proportion. IDDs in the fetus range from mild intellectual impairments to more severe and irreversible neurologic and physical stunting. Other consequences in pregnancy include maternal and fetal goiter, lower intelligence quotient scores in the offspring, and increased pregnancy loss and infant mortality. About 82% of pregnant women have inadequate zinc intakes, and that pregnant and lactating women consume 9.6 milligram per day of zinc, very well below the recommended intake of 15 milligrams during the second and third trimesters. Zinc deficiency is proposed to contribute to about 500,000 and maternal child deaths annually, mostly in developing countries. Zinc deficiency in pregnancy has been associated with impaired immunity, prolonged labor, preterm and postterm births, intrauterine growth retardation, low birth weight, and pregnancy-induced hypertension. Globally, it is estimated that 40 to 98% of pregnant women are vitamin D deficient, while 15 to 84% are severely deficient. Deficiency can be attributed to low intake of fortified foods, highly pigmented skin, and lack of sunlight exposure due to sedentary indoor lifestyles and use of sunscreens or protective clothing to prevent skin cancer. There is no universal cutoff for deficiency, but folate concentrations usually decline during gestation due to increased folate demands to facilitate increases in blood volume, hormonal changes, fetal and uteroplacental organ development. Folate deficiency results in the accumulation of homocysteine, which can increase the risk of adverse outcomes, including preeclampsia and fetal anomalies. Vitamin K deficiency, mostly from hyperemesis gravidarum, can also result to fetal nasal hypoplasia and fetal intracranial hemorrhage. Given the high prevalence of obesity in pregnancy as a result of current obesity epidemic worldwide, the adverse effects of maternal obesity for mother and child represent a major public health concern. Obesity is the result of an imbalance between daily energy intake and energy expenditure, resulting in excessive weight gain. It is a multifactorial disease caused by genetic, cultural, and societal factors. Other causes include reduced physical activity, insomnia, endocrine disorders, medications, the accessibility and consumption of excess carbohydrates and high sugar foods, and decreased energy metabolism. However, although associations between obesity and maternal fetal health are clear, the mechanism linking the obese maternal environment to short and long-term outcomes are complex and remain largely unknown. Obese pregnant women are at increased risk of maternal death and complications during pregnancy and labor. In the United Kingdom, the latest confidential inquiry into maternal and child health reported that more than half of deaths from direct or indirect causes during pregnancy or labor were in overweight or obese women. Obesity is associated with increased risk in almost all pregnancy complications, such as your gestational hypertension, your preeclampsia, gestational diabetes mellitus, delivery of a large for gestational age infant, and a higher incidence of congenital defects. Cesarean section rates are also much higher, and anesthesia may be problematic. Obese women often face difficulties in initiating and sustaining breastfeeding. Importantly, both obese mother and her child are prone to develop cardiovascular, metabolic, and neurological disorders later in life. An article published in the Official Journal for Reproduction and Fertility in March 2017 by K. Powell and T. Powell, entitled Effects of Maternal Obesity on Placental Function and Fetal Development, discussed that changes in placental function not only play a critical role in the development of pregnancy complications, but may also be involved in linking maternal obesity to long-term health risks in the infant. In this review, they examined the changes in maternal adipokines and obesity-related metabolic hormones and how these factors influence placental function and fetal development and may contribute to long-term health consequences of children born to obese mothers. Maternal adipokines, like your interleukin-6, your tumor necrosis factor alpha, your leptin, and adiponectin, link maternal nutritional status and adipose tissue metabolism to placental function. Adiponectin, an adipokine inversely correlated with insulin resistance, plays a crucial role in regulating immune responses, energy metabolism, and placental insulin sensitivity. Lean women have higher adiponectin compared to obese women throughout pregnancy, and maternal levels of adiponectin are inversely correlated with fetal growth, implicating a role for adiponectin in fetal development, metabolism, and placental function. This slide shows the role of adiponectin in lean and obese women to modulate fetal growth. Figure A illustrates adiponectin's influence on placental insulin response in lean mothers. Placental insulin signaling pathway in lean women where high levels of adiponectin leads to your PPAR alpha activation and ceramide synthesis to decrease placental insulin responsiveness throughout IRS1 inhibition, limiting amino acid transport to modulate fetal growth. Figure B, on the other hand, shows low maternal adiponectin in maternal obesity leads to fetal overgrowth. Low adiponectin in obese mothers allow for enhanced placental insulin sensitivity and activation of placental amino acid transport. This supports fetal overgrowth, which is associated with maternal obesity. Metabolic hormones and adipokine impact on placental function leads to fetal overgrowth. Factors associated with maternal obesity play a significant role in regulating placental transport and impact fetal development. Increased levels of your tumor necrosis factor alpha, observed in pregnancies complicated by obesity, stimulate the P38 MAPK pathway, and high maternal leptin and/or interleukin-6 levels stimulate your system's AL via the STAT3 activation. Placental toll-like receptor 4 expression is increased in obese women who often have high non-esterified fatty acids, leading to the activation of placental amino acid transport. High maternal insulin also activates your mTOR system AL to increase amino acid transport, leading to fetal overgrowth. This figure illustrates the role of adipokines and metabolic hormones in pregnancies complicated by obesity. Diversity in cytokine profiles in obese women may contribute to variation in fetal growth outcomes. In pregnancies complicated by large for gestational age fetuses, multiple metabolic factors like your insulin, leptin, interleukin-6, and tumor necrosis alpha, and low maternal adiponectin have been found to stimulate placental nutrient transport, contributing to fetal overgrowth. while in pregnancies complicated by hypertension, interleukin 1 beta and your S-FLT1 are upregulated, whereas your PIGF is decreased, leading to reduced placental blood flow, which on the other hand will limit fetal growth. Fetal brain development and long-term neurodevelopmental programming are linked to inflammation and placental serotonin production. Both poor and accelerated fetal growth are associated with similar long-term metabolic disorders in the children. Thus, maternal obesity propagates a vicious cycle of metabolic disorders passed down from the mother to the fetus in utero with long-lasting impact on child and adult health. Children born to obese mothers have a twofold increased risk for childhood obesity, metabolic, cardiovascular, neurological disorders, and an increased risk to develop neuropsychiatric and mood disorders, as well as cognitive impairments. 35% of women or children with autism also suffer from childhood obesity, further linking the in utero environment with a predisposition for both neurodevelopmental and metabolic disorders. The behavioral and cognitive deficits in children may be linked to alterations in your serotonergic system and your hypothalamic pituitary adrenal axis, resulting from increased pro-inflammatory cytokines and high-fat diets. Therefore, preconception assessment and counseling are advised. Physicians should encourage obese patients to undertake weight reduction program before attempting pregnancy. Individualized care and good clinical judgment will remain the cornerstone of the obstetric care of obese women. The main determinant of normal maternal weight gain during the entire period of pregnancy is the pre-pregnancy body mass index. Mothers whose BMI is less than 18.5 kilograms and those with greater than 25 kilograms, if uncorrected and not properly advised, possess a considerable impact on the developing fetus. The USA Institute of Medicine has recently published revised guidelines for gestational weight gain in underweight, normal, overweight, and obese pregnant women. There is a slower weight gain of about zero point 0.5 to 2 kilograms during the first trimester of pregnancy. According to IOM, one does not need any extra calories during the first trimester, while an extra 340 and 450 calories per day is needed in the second and third trimesters, respectively. Seeing the burden of malnutrition, how crucial then is maternal nutrition on the first 1,000 days of life? What if a span of just 1,000 days shaped our lifelong chance for health? Maternal, prenatal nutrition, and the child's nutrition in the first 2 years of life from pregnancy are crucial factors in a child's neurodevelopmental and lifelong mental health. Also, child and adult health risks, including diabetes, obesity, hypertension, may be programmed by nutritional status during this period. There are three crucial stages in the first 1,000 days: pregnancy, infancy, and toddlerhood. While the human brain contains or continues to develop and change throughout life, the most rapid period of brain development and its period of highest plasticity is in the last trimester of pregnancy and the first 2 years of life. At each stage during the 1,000-day period, the developing brain is vulnerable to poor nutrition, either through the absence of key nutrients required for proper cognitive functioning and neural connections, or through the toxic stress experienced by a young child whose family has prolonged or acute adversity caused by food insecurity. The human brain at 5 months post-conception is a smooth, bilobe structure that looks somewhat like a coffee bean. By 9 months, it has a gyri and sulci indicative of significant complexity, looking far more like the walnut-like adult brain. At birth, rapidly developing brain areas include your hippocampus and the visual and auditory cortices. In the first postnatal year, there is rapid growth of the language processing areas as well as early development of the prefrontal cortex that will control higher processing, such as attention, inhibition, and flexibility. The first 1,000 days are characterized by rapid rates of neuronal proliferation, growth and differentiation, myelination, and synaptogenesis. The brain consists of multiple separate regions, each with a unique growth trajectory that ultimately interconnect to make the complex organ that drives behavior. Thus, there is not a single common growth trajectory or single sensitive period. Nutrients are needed for the creation of new neurons and also fuel the formation of synapses, which provide the basis for learning ability. When a mother lacks adequate calories, protein, fatty acids, or key nutrients in her pregnancy, these vital neurodevelopmental processes can be impaired. Thus, the first 1,000 days is a time period that harbors the greatest opportunity to provide optimal nutrition to ensure normal development and is also the time of greatest brain vulnerability to any nutrient deficit. A healthy maternal diet of nutrient-rich foods is essential for the optimal development and functioning of a baby's immune system, metabolism, and musculoskeletal, as well as your cardiovascular systems. When pregnant women eat foods high in protein, essential fats, vitamins, and minerals, they are more likely to have full-term and healthy weight babies. Pregnancy is also a time when babies start to develop food preferences. What a mother eats during pregnancy influences her child's preferences for certain foods, as flavors from her diet get introduced to baby via the amniotic fluid. Infancy, from birth to a child's first birthday, is also a critical period when babies learn what and how to eat. It is also a time when their palates are trained and lifelong eating habits begin to form. When it comes to nutrition during infancy, for infants whose mothers can be breastfed, breast milk is a superfood. The World Health Organization, the American Academy of Pediatrics, the American College of Obstetricians and Gynecologists, as well as the Philippine Society for Obstetricians and Gynecologists recommend babies be exclusively breastfed with no solids or other liquids except vitamin or mineral supplement for the first 6 months if possible, followed by continued breastfeeding for at least 1 year alongside appropriate introduction of complementary foods. There is evidence that shows that babies who begin to eat solid foods before 6 months are at greater risk for chronic diseases such as obesity, diabetes, and celiac disease. Infants need nutrient-rich foods, especially those containing vitamin D, iron, and zinc to fuel their growth. Foods high in added sugar, salt, and saturated fats should not be part of an infant's diet. This food contribute to rapid weight gain in infancy, which is a risk factor for overweight and obesity later in childhood and can program a baby's taste buds to prefer very sweet, salty, or fatty foods. Early childhood is the best time to establish healthy eating habits. For a toddler to grow and thrive and to gain an appropriate amount of weight, they need to eat a variety of protein-rich foods, fruits and vegetables, whole grains, unsweetened milk, and other dairy products. Caregivers must also limit the amounts of saturated fats, sugars, and sodium that toddlers consume. Several factors influence the development of eating behaviors in young children. First, research shows that more opportunities children get to sample unfamiliar foods, the more likely they are to like and accept them. Second, context matters for children's consumption of healthy foods. During meal times, young children need loving attention from adults and a positive atmosphere free of pressure to eat. Research indicates that non-responsive feeding practices, such as encouraging young children to eat more or using food to control behavior, are associated with overeating and weight gain. Third, young children are powerfully motivated to imitate their parents and caregivers. Parents' consumption has been shown to be a strong predictor of their child's fruit and vegetable intake. As a whole, young children are most likely to develop healthy eating habits when adults in their lives model enjoying a variety of foods. Knowing now the importance of nutrition in the first 1,000 days, what type of diet can we recommend for our pregnant patients and for those planning to conceive? For those who are nutritionally at risk and are social demographically challenged? For those suffering from overnutrition pre-pregnancy and during pregnancy, as well as those with comorbidities like obesity, diabetes, dyslipidemia, and hypertension. For parents with infants and toddlers, it is most important to think holistically about the total profile of food and consider its nutrients as well as the component it contains. In lifestyle medicine, we promote consumption of a predominantly whole food, plant-based diet. A predominantly whole food, plant-based diet, also the diet promoted by the American College of Lifestyle Medicine, is a dietary pattern centered on whole grains, whole plant foods, including vegetables, fruits, legumes, nuts, and seeds. And processed foods and animal foods are limited or excluded. It is a diet wherein 95% of calories are coming from vegetables, fruits, whole grains, legumes, nuts, and seeds, and up to 5% of calories may come from meat, fish, dairy, and eggs. Eating a rainbow refers to eating a variety of plants of different colors. The colors come from different flavonoids and vitamins that are essential to health and disease prevention. Consumption of a wide variety of plant foods every day will help our patients meet the daily requirement of macronutrient and micronutrients. This is a summary of the macronutrient and micronutrient intakes during pregnancy based on World Health Organization recommendations, derived from Institute of Medicine guidelines, and expressed as recommended dietary allowance. When nutrients are discussed, it should be emphasized that there are two components: your macronutrients and micronutrients. The following are the macronutrients which are significant in maternal nutrition. Let us discuss each one briefly. Protein is involved in both structural and functional biological roles. Proteins are typically associated with meat and protein powder. But do you know that all essential amino acids originally come from plants and microbes? In general, plants contain all essential amino acids, and by combining an unprocessed starch like your rice, beans, potato with fruits and vegetables, protein requirements can be achieved. Protein sources from plants include legumes, which can deliver 10 grams of protein for half a cup, nuts and seeds, wherein 1/4 cup could give you 6 to 12 grams of protein, whole grains, wherein 1 cup, like your wheat and brown rice, can give you 6 to 12 grams of protein, so that proteins rarely needs to be prescribed when a balanced whole food plant-based diet is consumed. Carbohydrates are a commonly misunderstood macronutrient and should be addressed in the context of whole food versus processed foods. Whole food carbohydrates are ideal, healthy carbohydrates found in vegetables, fruits, legumes, tubers, and whole grains. Processed carbohydrates like refined or industrial sugars and flours are generally harmful and should not be eaten freely or minimized. Different sources of carbohydrates have variable digestion rates, thus their effects on blood glucose and insulin levels also vary. The glycemic index quantifies glycemic responses induced by carbohydrates from different foods. High GI foods cause a sharp rise in blood glucose level, which decline rapidly, whereas low GI foods such as fruits and vegetables have slowly digestible carbohydrates, which result in a lower postprandial glucose response. In a systematic review of 2 trials, low GI diets in 74 healthy women reduced the risk of large for gestational age infants. In pregnancies complicated by gestational diabetes mellitus, low GI diets reduce the amounts of insulin required to maintain optimal glycemic control. Fiber is a component of carbohydrates generally found in whole food, but it is often removed during food processing. Fiber is not digested, and therefore they increase the stool bulk, viscosity, and capacity to hold water. Fiber modulates fermentation. By changing absorption, it changes the content of our GI tract, thereby promoting the growth of healthier gut bacteria. Aside from the above benefits, high fiber intake lowers cholesterol, stabilizes the blood sugar, improves satiety, decreases cravings, thus decreasing one's risk of diabetes and colon cancer. The best sources of fiber are your legumes, whole grains, vegetables, fruits, nuts, and seeds. It is important to note that again, no fiber is found in meat and dairy products. An observational study of 1,538 women in the US showed that higher total fiber intake 3 months before and during early pregnancy reduced preeclampsia risk by attenuating pregnancy-associated dyslipidemia. Similarly, in 13,110 women from the Nurses' Health Study 2, the risk of GDM was reduced by 26% for each 10 grams per day increment in total fiber in pre-pregnancy, whereas higher dietary GL correlated with a greater risk of GDM. Thus, a low GI, low GL, and high fiber diet may be beneficial in preconception or early pregnancy for women at risk of developing GDM or preeclampsia or having LGA infants. Although it should not be prescribed with caution, it should be prescribed with caution for women at risk for your SGA. Essential fatty acids include your linoleic and alpha-linoleic acid, as well as their long-chain derivatives, your arachidonic acid, eicosapentaenoic acid, and your docosahexaenoic acid, or your DHA. These fatty acids are key structural components of cell membranes and are vital for tissue formation. DHA can influence the development of brain and retina in the fetus, while EPA may reduce the synthesis of thromboxane E2 from arachidonic acid, thereby potentially reducing the risk of preeclampsia and timing to parturition. Thus, dietary intake of fatty acids, particularly the long-chain polyunsaturated fatty acids, or your PUFAs, is important during pregnancy to meet the requirements of the mother as well as the developing fetus. Monounsaturated and polyunsaturated fats from healthy plant and seafood sources should therefore replace saturated and trans fat from processed food, meat, dairy, and tropical oils. Pure chia and flax seeds are excellent plant-based sources of omega-3 fatty acids. They are also rich in fiber and protein, thus can lower the risk of chronic diseases and excessive fat. In fact, just 28 grams of your chia and flaxseed can meet and exceed one's daily recommended intake of your omega-3. Micronutrients are chemical elements or substances that are essential in small amounts for growth and health. They are better known as our vitamins and minerals. Unfortunately, these micronutrients also belong to a category known as shortfall nutrients, wherein approximately 25% of the population underconsumes and are therefore at risk for deficiency. A whole food plant-based diet contains more than 100,000 phytonutrients, which may protect against chronic diseases by decreasing oxidation, decreasing inflammation, and increasing the strength of the immune system. Folate is a water-soluble B vitamin present in leafy green vegetables, yeast extract, and citrus fruits, such as oranges. Folate functions as a coenzyme and an integral for the synthesis of DNA and neurotransmitters, amino acid metabolism, protein synthesis, and cell multiplication. Folate concentrations decline during gestation, likely due to increased folate demands to facilitate increase in blood volume, hormonal change, and fetal and uteroplacental organ development. Supplementation with folic acid during preconception and early pregnancy is critical and can prevent 40 to 80% of NTDs, such as your spina bifida. Consuming a folate-rich diet, an intake of 400 micrograms a day of folic acid from fortified foods, supplements, or both, is recommended for all reproductive age women from at least 1 month before conception until at least 12 weeks gestation. Higher doses, around 4 to 5 milligrams per day, are recommended for women at high risk, like those with history of NTDs, diabetes, and is on anticonvulsant medication use. While intermittent doses, like 5 milligrams per week, may be used for women with poor compliance to medications, side effects, or poor lifestyle habits, including inadequate diets, smoking, and alcohol consumption. Iron is a vital nutrient and a cofactor for the synthesis of hemoglobin and myoglobin, which is necessary for cellular functions, including oxygen transport, respiration, growth, gene regulation, and the proper functioning of iron-dependent enzymes. In pregnancy, the demand for iron increases from zero point 0.8 to up to 7.5 milligram per day of absorbed ferritin, since it is needed to expand maternal erythrocyte mass, fulfill fetal iron needs, and compensate for iron losses, especially during delivery wherein there is blood loss. Maternal iron requirements therefore exceed average absorbable iron intake and in turn increases the risk of developing iron deficiency anemia. Plant-based foods, such as green leafy vegetables, contain non-heme iron, which makes up the major fraction of dietary iron, although heme iron food from animal sources have higher bioavailability. A 2015 Cochrane meta-analysis of 44 trials involving 43,274 subjects reported a 70 and 57% reduction in maternal anemia and iron deficiency at term, respectively, in women receiving preventive iron supplements compared to no iron or placebo. Periconceptional supplementation with 30 to 60 milligrams per day of elemental iron is recommended for women during pregnancy for preventing anemia, with 60% as the preferable dose in regions where maternal anemia affects greater than 40% of pregnancies. Iodine is an essential nutrient for regulating growth, development, and metabolism via biosynthesis of thyroid hormones, including your T3 and your T4. Iodine is obtained mainly from fortified salt, but it can also be sourced from kelp and seafood, as well as dairy or plant foods in places with iodine-fortified animal feed or iodine-rich soil. Hence, a dietary iodine intake of 250 micrograms per day is recommended for pregnant and lactating women. In regions where only 20 to 90% of households use iodized salt, periconceptional supplementation may be required with universal salt iodization programs as implemented and upscaled. Calcium is an essential nutrient for bone mineralization and a key intracellular component for maintaining cell membranes. In pregnancy, calcium is actively transported across the placenta and maternal calcium demands increase, particularly during the third trimester. More efficient uptake and utilization of calcium occurs naturally during pregnancy via physiological adaptations, including increased calcium absorption stimulated by hormones and enhanced retention of calcium by your kidney tubules. Milk and dairy products are the best sources of calcium, and it can also be derived from leafy green vegetables, nuts, or fortified foods, including flour and dairy alternatives like your soya, your rice, your oat milk products. Zinc is an important catalytic component of over 200 enzymes and structural components of several nucleotides, proteins, and hormones. Zinc is present in many foods, but higher levels can be found in meat, seafood, milk, and nuts, whereas diets high in fiber or phytate can reduce the bioavailability of zinc. Two separate meta-analyses reported that zinc supplementation during pregnancy reduced the incidence of preterm birth by 14% by reducing maternal infection, a primary cause of prematurity. B-complex vitamins are water-soluble vitamins that can act as coenzymes in several intermediary metabolic pathways for energy generation and blood cell formation. The requirement for these vitamins is heightened in pregnancy due to increased energy and protein needs, particularly during the third trimester. B-complex vitamins are obtained primarily from animal sources, including meat, poultry, fish, and dairy products, and can also be found in fortified cereals, legumes, and green leafy vegetables. Supplementation with vitamin B12 is advised especially for women consuming a predominantly whole food plant-based diet. Your vitamins A, C, E, and K are your water-soluble vitamins. Physiological functions of vitamin A include vision, growth, bone metabolism, immune function, gene transcription, as well as antioxidant activities. Both vitamin C and E function synergistically to promote antioxidant defenses and inhibit free radical formation to prevent oxidative stress. Vitamin C is also involved in synthesizing collagen and has an important role in mobilizing iron from stores and enhancing the absorption of dietary iron, preventing megaloblastic and iron deficiency anemia. Retinoids are obtained from animal sources including eggs, dairy, liver, oil. Carotenoids such as beta-carotene are obtained from plant sources such as dark or yellow vegetables including kale, sweet potatoes, and carrots, and can be converted to vitamin A in the liver where vitamin A is stored. Many fruits and vegetables, including guava, citrus fruits, tomatoes, broccoli, are rich in vitamin C, while vitamin E is found in nuts, wheat germ oil, vegetable oils, and some green leafy vegetables. Also worth mentioning are the beneficial non-nutrients, which include antioxidants, anti-inflammatory molecules, your phytochemicals, your polyphenols, phytosterols, glucosinolates, and carotenoids, which are products of secondary metabolism in plants that recently have evidence-based reviews supporting their potential to alter the risks of various diseases in humans. Consumption of a predominantly whole food plant-based diet will give us the benefits of these bioactive non-nutrients. In a Cochrane meta-analysis of 15 trials, including 2,833 women, vitamin D supplements during pregnancy reduce the risk of preeclampsia, low birth weight, and preterm birth. Sunlight is a better source of vitamin D than dietary sources because UVB radiation will transform a precursor of vitamin D in the skin into your vitamin D3. A 5 to 30 minutes sunlight exposure at least 2 days a week is enough. Microbes of the gastrointestinal tract are associated to health and disease. Their functional coexistence within the gut can be manipulated by altering their environment, of which host nutrition has the greatest impact. Although disease causality has not been directly attributed to microbiota, researchers hypothesize that early life exposure and assembly of microbes in the gut influences host development. The developmental origins of health and disease, or your DOHAD hypothesis, proposes that an early life window exists where environmental exposures, including mode of birth, nutrition, breastfeeding, infection, and antibiotics, lead to programming effects that can affect long-term health. During the first 1,000 days of life, host immune, endocrine, metabolic, and other developmental pathways mature in tandem with the microbiome to achieve a mutualistic relationship. Transient disturbances to microbial communities, or your dysbiosis, during this critical window of development have been associated with immune-mediated metabolic and neurodevelopmental disorders. An article published by 4G et al. In May 2020 entitled The Impact on Maternal and Early Life Malnutrition on Health, a Diet Microbe Perspective, discussed the potential implication of maternal and infant diet-induced microbial and host changes surrounding early life, protein, fat, carbohydrate, iron, vitamin D, and vitamin B12 malnutrition. The fetal programming hypothesis suggests that maternal nutrition and exogenous factors have long-term metabolic, immune, cardiovascular, and central nervous system effects on their offspring. So we discussed this earlier in this part of the lecture. Moreover, the missing microbe hypothesis that occurs over generations is believed to increase disease susceptibility due to suboptimal microbe host-mediated immune development. For instance, the adoption of a low-fiber diet is considered a major player responsible for the intergenerational disappearance of microbes that may promote gut stability and resiliency. Exogenous factors that alter early colonization and succession of microbes in the gut may delay gut maturation and development. Disruptions to microbial networks during this critical window of development are associated with asthma, allergies, diabetes, inflammatory bowel disease, and obesity. It is during this time that the host forms a mutualistic or immune-tolerant relationship with microbes and is thought to alter disease susceptibility. There is a constant struggle between cause and effect with respect to microbial dysbiosis and disease outcome in the study of malnutrition and the microbiome. Although the debate to what effect the microbiota contributes to disease remains unclear, it is reasonable to conclude that both gut microbes and environment contribute to pathogenesis of malnutrition and undernutrition. Dietary components play a major role in maintaining microbe-host interactions that may promote intestinal health. Therefore, nutrition is an important tool that can be manipulated to restore beneficial microbe-host interactions that enhance intestinal integrity and health. Environmental enteropathy is a subclinical disorder associated with altered diet microbe-host interactions and characterized by intestinal injury, nutrient malabsorption, and inflammation. Environmental enteropathy can induce stunting and wasting through poor digestion and autoimmune dysfunction rather than food shortage. Dietary fiber and resistant starch support homeostasis through their effects on the intestinal mobility and microbiota. The recommended adequate intake of dietary fiber is 14 grams per 1,000 kilocalories, equating to approximately 28 to 36 grams per day in human adults, but a number of experts believe it should be closer to 50 grams per day. The bulking properties of dietary fiber positively influence gastric emptying, fecal frequency, and satiety. The production of your short-chain fatty acids, especially butyrate, provides direct energy to gut epithelial cells and promotes intestinal homeostasis by maintaining a hypoxic environment, mucus production, and antimicrobial peptide secretion. Commonly known as prebiotics are microbial accessible carbohydrates. Fibers and starches that encourage SCFA production also promote microbial diversity and resiliency. Thus, a MAC-deficient diet is hypothesized to have contributed to gut microbe extinctions across generations, leading to reduced diversity and short fatty acid production and dysbiosis associated to disease later in life. This is my parting slide. Put simply, nutrients flow across generations. A baby develops from an egg in its mother that was created and nourished by that baby's grandmother during her pregnancy. This means that a woman's nutrition directly affects not only her own child's health, but her grandchild's health as well. As physicians, we want to end chronic disease where it starts. Thanks to Barker's theory and subsequent insights into when foundations of chronic diseases are laid, we know that vulnerability to disease is due to poor growth early in life, and that improving the quality of women's diet can turn the tide against chronic diseases. With this knowledge comes the responsibility to take action. The challenge, however, is that these diseases are becoming ever more common, and the effort to reverse this growth requires not only changes in individual behavior, but more importantly, societal changes as well. Let us contribute to a movement to inspire changes to our current food culture and to prioritize population health so that someday chronic disease is the exception, not the rule. Thank you all for your kind attention.